Bismillah ar-Rahman ar-Rahim. Welcome in this new meeting of Egyptian Society of Nephrology and Transplantation, online CME meetings in our usual time, 9 p.m. Cairo time, and Wednesday, as usual. Hope you had very fruitful summer vacations last month, and we are starting in first week of September to start our new season in this year. It's my pleasure to start by an important topic in hemodialysis, and this will be controlled by a great moderator, and the speaker is one of the eminent speakers in ESNP today. We are honored to have Professor Saied Khamis as the speaker. He is the head of Professor of Nephrology and Internal Medicine, Menofea University. He is the head of the Nephrology Department in Menofea University, and Professor Saied is one of the members of national guidelines, and he is well known by his scientific activities in all the conferences in Egypt and usual scientific activities all over the year, every now and then teaching young generations, and even in all of the scientific activities, he is one of the very active members, and we will really want to thank him for his activities in CME all over the year. And I'd like to welcome our great moderator today, Professor Saied, Professor of Nephrology and Internal Medicine at Ain Shams University. Professor Hisham is the Vice President of Egyptian Society of Nephrology and Transplantation and the Chair of Hemodialysis Chapter in Egyptian Society of Nephrology and Transplantation, and the Chair of Hemodialysis Committee in African Association of Nephrology, Afghan. Our topic today is one of the important topics. One of the very important symptoms that we meet every now and then in our dialysis patient, during the session, after the session, in between the sessions, fatigue. It is very common to have patients that tell you, I am so fatigued and don't know why. What are the causes of this fatigue? How can we diagnose this, the cause? How can we go to treatment? This is the topic of our session today. And I will leave the floor to Professor Hisham to lead this session and further introduce Professor Saied and go on with his lecture, Fatigue and Underestimated Symptom in Hemodialysis. So please, Professor Hisham, welcome and go on.
Thank you very much, Professor Dr. Yasser Abdelhamid. I am honored to be in the Welcome Back talk today after summer vacation. I hope that all enjoyed some relaxing time. And I thank you that we had to learn from Professor Saied Khamis, Professor of Nephrology at Menofea University. He will touch up a very common patient symptoms of fatigue that could be just a symptom, or nephrologist ignoring such symptoms, but it's for sure carries a lot of morbidity and mortality. We have to estimate it that it's more than 60% of patients on dialysis have experiencing fatigue, either interdialytic, intradialytic, just after dialysis, or intradialytic period. So fatigue is a common finding. We have to go through different causes and pathogenesis, how to treat, how to diagnose, and I am sure, and I have the prophecy that Professor Saied Khamis will carry a lot of information. So please keep all of us seat warm, because the discussion will carry a lot of question and answer later on. So please, Professor Saied, you can go on.
Bismillah ar-Rahman ar-Rahim. Thank you, Professor Yasser, and thank you, Professor Hisham, for this sweet introduction. Actually, as you said, Professor Yasser and Professor Hisham, that fatigue is a very common symptom in our hemodialysis patient. And unfortunately, it is, I cannot say ignored or neglected, but at least it is forgotten by most of us, by most of the nephrologists. So I hope tonight I will shed some light on this big topic or a challenging topic. Let us start. Our agenda today is brief introduction to this very common issue in our dialysis patient, the post-dialysis fatigue as a forgotten major issue, and we shall give a hint on the prevalence and its pathogenesis, and this how to assess or how to measure the post-dialysis recovery time, which is the surrogate marker or a sign of this post-dialysis fatigue, and why it does matter, this post-dialysis recovery time. In the meantime, also, we shall, inshallah, throw light on the HD patient symptomatic burden, which is very debilitating and pressuring on our patient, and how can we mitigate this symptomatic burden in our lovely, beloved patients. And by the end, we shall give a hint about the dialysis recovery time can be improved in our patient, and what are the modalities or the tools we can do to improve this dialysis recovery time. As we know that all nephrologists are aware that patients receiving maintenance hemodialysis have extremely, unfortunately, poor outcome compared to the general population. Despite the difference between countries, or slight difference between countries, slight improvement over the last decade, still mortality rates for patients receiving hemodialysis unacceptably high. For example, in the state, almost 1/4 of the patients beginning hemodialysis therapy died in the first year. And half of these patients, that means 50%, die within 3 years. Plus, the overall quality of life, which is more important than the longevity itself, is also very poor. And the burden of the disease is extremely high. CKD, especially the end-stage renal disease patient or the dialysis patient, frequently experience unpleasant symptoms. These symptoms, as we know, that can be gastrointestinal, psychological, neurological, cardiovascular, dermatological, like itching, I mean uremic itching or uremic pruritus, painful conditions, sleep disorders, erectile dysfunction, and last but not least, the post-hemodialysis or intradialytic fatigue. No one can deny that uremic toxins is a reason behind these symptoms. Fatigue surrounding hemodialysis treatment is very common, as Professor Hisham said, and often debilitating symptom that impact patient quality of life. The intradialytic fatigue either develops or worsens immediately before hemodialysis and persists through the dialysis treatment, or develop and worsen after dialysis, or what's called post-dialysis fatigue, or PDF, and may persist for hours even after dialysis. Up till now, no consensus how to measure post-dialysis fatigue, and we shall come to this point after a while. Estimate for the prevalence of post-dialysis fatigue, it ranges from 20 up to 86, or even more than 90%. This is likely due to the variation in the methodology of ascertainment and the participant characteristics. So there is a great difference between one study and the other. Several theories seek to explain the pathophysiology of post-dialysis fatigue, and we shall come to this point. So why post-dialysis fatigue is a major issue, or why, as a nephrologist, we forgot to focus on this issue? Let us talk about the size of the problem of this, I mean the post-dialysis fatigue. Prevalence estimate post-dialysis fatigue, as we said, from 20 to 86%. Variation, as we said, due to different parameters used in, or measurement used in these different studies. For example, in the dialysis outcome and the practice pattern, or what's called DOPS study, 32% of the patient reported recovery time shorter than 2 hours. And about 40% reported 2 to 6 hours, and 17% 7 to 12 hours. And lastly, 10% reported longer than even 12 hours. That means the patient will suffer or is still suffering from tiredness or exhaustion post-dialysis up to 12 hours, almost till the next session. Each hour, this is very important statement, each hour of increased recovery time after dialysis was associated with a 3% increase of the risk of hospitalization and 5% increased risk of death. That means the mortality will be raised up to 5% with each hour after these first 2 hours. Not all studies use the same cutoff of dialysis recovery time or time to recover from dialysis, which limits the comparison between the different studies. And this is clear in this figure, as we showed, it's shown here, that the prevalence of post-dialysis fatigue and dialysis recovery time in the upper figure, or A, the prevalence of post-dialysis fatigue has varied between studies from 20 to 86, as we said, depending on how PDF was defined and asserted. In figure B, the figure below, the proportion of patients reporting time to recover from dialysis or post-dialysis recovery time of various lengths has also varied between
we can stop recording.
Go on. تفضل دكتور سعيد.
So we shall throw light on new insights of post-dialysis fatigue, and I would like to show you, all of you, this very interesting study done by Jacobson et al. Reviewed 65 international studies comprising 1,700 participants. What did they find? They found the following. Number one, patient experienced debilitating, relentless exhaustion because of, as Professor Tariq said, HD-related fatigue, which encompasses their whole body and can persist beyond the immediate treatment period. And hemodialysis-related fatigue restricts patient ability to engage in usual activities. This is because that the time needed to get to clinic and complete treatment about 3 times per week, which is very exhausting, needing to rest between treatments and managing energy reserves. Hemodialysis-related fatigue can leave the patient in a miserable condition, feeling vulnerable to criticism of laziness when they need to rest. And consequently, patient feels that hemodialysis-related fatigue can lead to misunderstanding when they fail to meet the expectation of friends and family. What's the current guidance say on this issue? The NICE 2018 guideline on renal replacement therapy conservative management highlight fatigue as a possible general symptom of renal replacement therapy. At present, guidance only relate to the potential intervention for decreasing post-dialysis fatigue resulting from either dehydration by using devices to improve estimate of the intradialytic fluid removal. Finally, what are the implications of this? The authors claim that this review may help increase awareness and education of persistent and the pervasive nature of fatigue in hemodialysis patients. It has highlighted the importance of what's called the standard outcome in nephrology in hemodialysis, or SONG-HD initiatives, which currently validating a measure of fatigue that reflects the dimensions that are most important in hemodialysis patients. we hope that this should aid in measuring the impact of intervention, but as Professor Hisham said, the measurement, it is difficult to measure exactly the hemodialysis, the post-hemodialysis fatigue, because a lot of studies studied this issue, and I will come to this point after a while. In the dialysis population, physiologic and other behavioral treatment-related individual characteristic may be correlated with fatigue, as this figure shows. Also, we should not forget the psychological issue, especially the depression. Depression is one of the most important causes of post-dialysis fatigue, and it could be vice versa. I mean, depression can lead to fatigue, and fatigue can lead to depression, and a vicious, relentless circle started. What about the pathogenesis? It's still also in the mysterious issue. The cause of fatigue after hemodialysis are not clearly understood, although some studies have reported factors associated with post-dialysis fatigue, or what's called post-dialysis recovery time. This will come in the coming figure, the coming slide. Essentially, a few theories have been proposed. The first theory is, as Professor Hisham said, is inflammatory cytokines like interleukin-1, 6, 10, and especially the tumor necrosis alpha, TNF-alpha during or after dialysis. Another study showed no relationship between these pro-inflammatory cytokines, and surprisingly, it showed that the anti-inflammatory interleukin-10 is increased with increasing the post-dialysis recovery time. This issue actually warrants further exploration. Honorably, we studied this issue, our group in Monofia, a few years back, regarding the TNF-alpha in the post-dialysis fatigue, and we couldn't find any correlation between the level of TNF-alpha and the post-dialysis, the incidence or the prevalence of post-dialysis fatigue. Second theory regarding the pathogenesis is the dysregulation of the hypothalamic pituitary adrenal axis, which is the key of neuroendocrine system that adapts to emotional, physical, chemical, and immune stressors, and the issue of raised serum cortisol in this patient, like the cancer patient, whereas you can find also the cortisol is high in such a patient. It's unclear at that time whether hemodialysis procedure impacts these systems in such a way that may contribute to post-dialysis fatigue. The last theory, the third one, is some have proposed that rapid shift, as Professor Tara and Professor Hisham said, in osmolality, and Professor Faisal, in osmolality and the fluid during hemodialysis may contribute to post-dialysis fatigue and the other dialysis-associated symptoms. Studies comparing post-dialysis fatigue after dialysis against high sodium and low sodium dialysate arrived at conflicting conclusions. So these were often limited by the small sample size, and most of these studies are observational studies. What are the associated factors that can lead to post-dialysis fatigue? Our patient, we cannot deny that they have a lot of comorbidities. In the setting of this conflicting and limited data, no clear theory currently explains the pathogenesis of post-dialysis fatigue. Observational studies identified associated factors, which will come in the next table. These can be organized into cardiovascular effect on hemodialysis, laboratory abnormalities, and clinical factors. Elevated sodium serum lactate, elevated serum lactic acid levels may contribute to post-dialysis fatigue due to tissue hypoxemia, due to hypotension during dialysis. Also, dialysis recovery, post-dialysis recovery time showed a U-shaped association with ultrafiltration rate. That means such the rate below 5 milliliter per minute or above 15 milliliter per minute was associated with shorter post-dialysis recovery time, and UF between 5 and 15, it's okay. An association between intradialytic hypotension and post-dialysis fatigue has not clearly proven due to conflicting data. As Professor Hisham said, depletion of branched chain amino acid during hemodialysis may also contribute to post-dialysis fatigue, as these branched chain amino acid compete for the 5-hydroxytryptamine, which is essential for the brain tissues. A history of depression, as we said, have been found in several studies associated with post-dialysis fatigue and prolonged post-dialysis recovery time. Last but not least is the sedentary behavior and functional disability are also associated with post-dialysis fatigue. The recovery time after hemodialysis is inversely, as we said, associated with altered filtration rate. And this study done by the Italian groups, they concluded that recovery time is inversely associated with altered filtration rate in patients on chronic hemodialysis. Whether this is an indication that high altered filtration rate is recommended to reduce dialysis recovery time needs to be studied in details. This figure also showed that the course of fatigue in hemodialysis patient is markedly linked to the depression or the severity of depression. These are the factors associated with increased post-dialysis fatigue and can be categorized as the cardiovascular, the hemodynamic effect of hemodialysis, the lab abnormalities, as we mentioned, and the clinical factors. This table showed the studies evaluating factors associated with post-dialysis fatigue. And these studies, actually, a lot of studies starting from even 1996 and up to 2020. And all these studies showed that these associated factors can share in a way or another in the development or in the pathogenesis of this post-dialysis fatigue. How to measure or how to assess this post-dialysis fatigue? As you see in this table on the right side or right-hand side, many studies are there, or many what's called questionnaire-based measures of PDF or post-dialysis fatigue are there. But no one of them you can having high sensitivity or specificity, and you can recommend in the busy daily life. I mean, as a nephrologist, you cannot catch a paper in your hand and fill in the space what is, or the text, what is this, what is that. So there is another productive method to assess these post-dialysis fatigue, what's called, as Dr. Hisham said, the post-dialysis recovery time. So hence the post-dialysis recovery time importance comes. Why it does matter this? In the study of Reiner et al., he asked their patient on 60,000 patients from different countries, and it was a part of the DOPS study in 2014. How long does it take you to recover from dialysis session? And all of us simply can ask our patient in the dialysis round this simple question. As we said, each 1 hour increment in post-dialysis recovery time was associated with 3% hospitalization and increased risk of death by 5%. So if you do intervention for this issue, and what's called doing this nocturnal hemodialysis, this post-dialysis fatigue became only in minutes, and 98% will not suffer from this post-dialysis fatigue. In the other part, this recovery time, the risk of this is if it is 8 hours, this post-dialysis recovery time, it will be 48, almost 50%. If it is 4 hours, it will be 28. What is 1 hour after this first 2 hours, I mean 120 minutes, it will be 5% increase in mortality. As Professor Hisham said, this dialysis recovery time considered more than just another serum album. So it is very, very crucial and very important issue to be focused on. In our hemodialysis patient, as Professor Tariq said, the patient and his partners will focus more not on the longevity of their dialysis patient, but they will focus on mitigating the symptom burdens they suffer, these patients. So can dialysis recovery time be improved, which is the more important in this symptom of our hemodialysis patient? Symptoms identified as more important, including fatigue, hypotension, cramping. Fatigue is very common and is a complex phenomenon, as we said, that significantly decreases the health-related quality of life among hemodialysis patients. Patients consistently rate hemodialysis-related fatigue as an important patient-defined health outcome above survival. That means more important than survival and regarding the mobility and the pain. Treating symptom to improve the quality of life in patients with chronic hemodialysis by these Italian groups, they found that patients on chronic hemodialysis deserve a better quality of life for sure, and this deserving this better quality of life necessitating that we should give adequate or more precise statement, optimal rather than adequate dialysis to our patient. It doesn't matter only it is just dialysis. It should be optimal dialysis if we can. So managing symptom burden associated with maintenance dialysis, symptoms that kidney care teams should address, some symptoms considered when identifying those most important by our patient. Can we mitigate the patient symptom burden? No one can deny that the job of artificial kidney is to replace the adrenal function of normal kidney, which is not completely for sure. It's only maximum 10 to 15%, which means maintaining hemostasis and maintaining his survival or life. There is now increased focus on mitigating the patient's symptomatic burden with view of improving both symptom outcome and in the meantime, which is more important, is the quality of life. When our patient dialyzed 3 times a week, they swing mildly back and forth from acidosis to alkalosis, from hyperkalemia to hypokalemia, from fluid overload to volume contraction. This is what's called dialysis unphysiology or dialysis-induced systemic stress, which is a big topic actually. But when patients are switched to daily dialysis, if it is affordable or applicable, the fluctuations are smaller for sure. So with the current 3 times a week hemodialysis, there is a 70-hour killer wait. I mean the interdialytic time. From Friday to Monday, I'm talking about the Western countries. It can be different in our countries. Studies have shown that this rate of dialysis patient on Monday or Tuesday is twice that of other weeks. That means that the post-weekend mortality is very high. The long time between dialysis is clearly very dangerous when the patient gets sick and die. So again and again, we should focus on mitigating the patient's symptomatic burden. How to manage study intervention can be categorized as changes in the hemodialysis prescription, treatment of depression, treatment of depression, and exercise. The lack of adequate method for measurement, lack of provider awareness, we should underline this issue, lack of provider awareness, and the complex pathogenesis of this issue, I mean the fatigue, have confounded the development of effective intervention to treat fatigue. There is a strong need to develop improved assessment methods, investigate the role of other contributing factors, especially inflammatory mediators in fatigue and end-stage renal disease. On the left-hand side, in this box, we can find all the proposed methodologies or tools to improve the post-dialysis fatigue or post-dialysis recovery time. Starting from high dialysated sodium, as Professor Hisham said, sodium modeling protocol, glucose-enriched dialysate, cool dialysate, that's very important one, and others. Unfortunately, all these studies mentioned here, many of these studies employed small size, short duration of intervention, and were performed before the modern dialysis technique and before the touch of Professor Hisham to be there, which limits its interpretation. Other intervention also studied in a small group of patients, like the ESA, the anabolic steroid, which is not recommended actually, other antihypertensive medication, acupuncture and acupressure, L-carnitine, which is still also has nothing to do with the fatigue. So these studies generally evaluated fatigue globally without discrediting post-dialysis fatigue from chronic fatigue. This is an example of a small study, pilot study, studied this issue. I mean, the intervention with to mitigate the effect of fatigue on our patient. And they studied these 4 issues: sodium and dialysate, the QB, the temperature, and the changes in the dialysis recovery time. And what they found that reducing blood flow concern whether this would affect the KT over V or not, and the patient actually showed improvement in the post-dialysis fatigue. But we should not forget that this required change in the common practice in the state, given the median US blood flow rates there is 450 milliliter per minute, compared to 350 in Belgium, France, and Sweden, and UK, and 300 milliliter per minute in Australia, Germany, Italy, and the lowest one in Japan is 200, maybe because the surface area of their patient is small. The longer dialysis, one of the recommended issues also to get rid of this post-dialysis fatigue. The dialysate sodium, as Professor Hisham said, is still also a debatable issue. But always keep in mind that keep the dialysate sodium to below or above the serum sodium of the patient according to his baseline blood pressure. Cooling of dialysate, which is a hot issue in the last decade, actually, and it's a virgin area for researches actually. And we are running in Monofia now one of these researches regarding the correlation between this cooling of the dialysate and the effect on post-dialysis recovery time. Cooling dialysate temperature below 37 improve hemodynamic stability for sure, as we know, but it could be also as a tool to minimize the effect of post-dialysis fatigue on our patient. Temperature can play a role in the dialysis-related dialysis recovery time. Therefore, it deserves consideration to be explored in patients with prolonged post-dialysis recovery time. To sum up, can the dialysis recovery time be improved? Yes, it can be with collectively using all these measures we mentioned together if possible. And prolonged dialysis is one of these measures, I mean, like prolonged nocturnal hemodialysis, and also in the meantime, the hemodiafiltration. And we cannot forget the recently published convince study that it decreased the hemodiafiltration versus high flux dialysis. The hemodiafiltration actually resulted in a lower risk of death from any cause than conventional high flux hemodialysis. Other associated factors may influence post-dialysis fatigue are intradialytic blood flow rate and UF rates. So my conclusion is that we have long addressed the quality of dialysis to revolve around achieving specific measurements that like lab result, KT over V, and I was intended to put the T in capital letter, as Professor Hisham said always, and recommends that T is more important than the K and B. And the parathyroid, the hormone, etc., and the dry body weight. So we are treating figures, or we are treating patient. We should focus that we are treating a patient, not numbers. Post-dialysis fatigue is a common and complex phenomenon that significantly reduces the quality of life. Dialysis recovery time is a quantifiable, validated measure of post-dialysis fatigue. Ignoring this patient-reported feedback could lead to disconnection between us as a nephrologist and the patient goals, and consequently will lead to reduced patient adherence and compliance. Post-dialysis fatigue is associated with several clinical factors, as we said, like cardiovascular, hemodynamic, etc. Clinical trials may have suggested utility of cold dialysate, frequent hemodialysis, clearance of large molecules, treatment of depression, which is very important, and exercise as a potential treatment. Existing studies are often limited by sample size, lack of control group, observational design, a short intervention duration. Last but not least, that powerful studies are needed to establish the pathophysiological and management of this important and debilitating symptom. This slide from Professor Hisham, thanks for him, that we should not forget that the tension between dialysis patient, desire of nephrologist goal, impact of overall health outcome, always are pressuring on our patient. Continuous diet restriction, fluid intake restriction. We cannot extend your session because there is many logistics. We cannot offer you this. So try to treat the symptom burden, namely post-dialysis fatigue, which is very embarrassing to our patient and make them more miserable, and they are already miserable in their life. And I hope that you are not tired up till now, and thank you so much.
Thank you, Professor Saied, for this very interesting talk, highly comprehensive talk. And Professor Hisham.
Thank you very much, Professor Dr. Saied. It's very comprehensive. You touch all of the pathogenesis described already as well from our pioneer professor here attendees. As Professor Tariq Elbaz and Professor Faisal Shaheen said, that it's great symptoms, and some could be related to multifactorial effect. It could be osmolarity changes or due to high ultrafiltration. And you can give us a slides as well from that in the conclusions that prolonged dialysis or frequent dialysis improve the fatigue, meaning that the osmolarity changes is still one of the big player in such symptom. So we can have the final opinion from professors attendees. We have here Professor Faisal Shaheen, Professor Tariq, Professor Manal Deeb.
Professor Tariq Elbaz wants to comment to Professor Hisham.
Yes, sure.
Thank you very much, Professor Saied, for a very comprehensive talk, and you touched a rather important point that should be more and more talked about. We want everybody to understand just the beautiful statement you said, that we are not treating numbers and ranges. We are treating patients who have complaints, and it is our prime job is to alleviate pain. You alleviate pain by a pill, by a kind word, by whatever. So this is something very important. I liked very much that you brought back the concept that I believe in so much, which is the long dialysis session. I know that this is something difficult to be applied on a national level, but always the long dialysis will always be an answer to a lot of the problems that our patients are complaining of. Also, you mentioned that night dialysis, which we had many years ago, an experience in Al-Azhar, and we did show how patients improved by measuring various parameters by night dialysis. So again, this was very nice to hear that night dialysis is reducing this time of fatigue, post-dialysis fatigue. So this is another issue. I don't know how we could apply it in most of our dialysis units. Yet again, is good. compared to what you mentioned in the recent study related to hemodiafiltration, I'm sure Professor Hisham Saied will tell us a lot about hemodiafiltration. We all realize and now we understand that the results of hemodiafiltration could be much better when compared to other modalities. Yet again, the access to hemodiafiltration everywhere, nationwide, I mean, is not quite possible. So does the panel think of these alternatives that maybe are simpler to apply, such as the long dialysis session? Can we really apply that even? It doesn't have to be everywhere. Do you think, Professor Hisham or Professor Saied, we could apply such protocols of dialysis different from what we are doing today to help our patients get rid of this symptom?
Yes, Professor Saied, you can start and I will continue.
Thank you, Professor Tariq. Can you repeat your question, Professor Tariq, please?
Now, you showed us clearly that
prolonged sessions is much better in the outcome.
Yeah.
And night dialysis as well.
Yeah.
How much do you think that this is applicable? ولا ما هو كلام إنشا وخلاص? Can we really do it?
Right, you are. It really.
It's very difficult in implementation, for sure.
Very difficult to afford or to apply in Egypt. I mean, as a third world country or with limited resources. So it is theoretical rather than practical, as you said, Professor Tariq.
It needs as well other equipment. So if you are doing nocturnal dialysis in a center, you need a very flow rate to be decreased. You have to need to monitor the patient all the time. You have to keep in mind that complication can happen overnight. But in general, the one of the dialysis adequacy that equal to transplantation in quality of life is nocturnal dialysis. So nothing in dialysis except nocturnal dialysis equal transplantation except nocturnal. For sure, it's a best, but unfortunately, it's difficult to implement in different centers.
Right, you are. By the way, came back.
Let me.
الحمد لله الكهرباء رجعت يعني.
طيب الحمد لله.
And ask a question for myself.
Yeah.
What about the reports? Is there any report of the different dialysis fatigue, duration, intensity, etc., by the use of different types of membranes with different types of clearances, albumin loss in the view of recent membranes, as always Professor Hisham said, and if there is any reports about the different difference regarding the use of these types of membranes?
I will leave the answer for Dr. Hisham.
Yes, I didn't hear you well, Yasser. You are mentioning the different dialysis membranes.
It's different dialysis membranes. Is there is any reported effects regarding this?
No, there is no effect. In the fatigue symptoms, there is no described special dialysis membrane. As you know, that all dialysis membrane are biocompatible right now. Even with the medium cutoff, they didn't improve the fatigue. But some clinical trials or observational studies saying that hemodiafiltration medium cutoff may improve removing the middle molecule, which play a major part in the fatigue syndrome. But still, there is no big data to encourage such patients to go for medium cutoff or hemodiafiltration to improve their symptoms. You can have other benefits from removal of middle molecules, but it's not directly related, as all the parameters Professor Saied said, there is no direct single parameter related to fatigue in all these scenarios.
The question was, I was imagining really the medium cutoff membrane was directed for this type of membranes in the view of albumin loss, but surprisingly enough, you mentioned can improve due to we can imagine the weight of clearance against the albumin loss. And you said that the weight of clearance is more and results in improvement of fatigue, not as I imagined that albumin loss had a bad effect on this symptom.
It's an equilibrium between, for example, you can remove more leptins, you can remove middle molecules, you can improve the appetite, you can just supplying the proteins content higher. As you said, that there is a lot of albumin loss, 4 grams. What's meaning that it's not a blind, it's a blind technique in hemodialysis. If you reach and touch up 60,000 Dalton, which is the albumin molecules, around 7 nanometer in diameter. The radius is 3.5 nanometer, which is bigger than usual high flux. So it is a double size of pores. You will lose as well important nutrients. So you have a waste and you have an important. One of the important is albumin, but what's else? A lot inside. So I don't go with the medium cutoff. I can go to superflux because it's clearly much better and with lower albumin loss, usually 1 or 1.5 gram maximum.
Okay, thank you. We have many comments and questions. The first one from Dr. Adina Abdelatif.
Yes, but before their question, I'm just asking that a very important question to Dr. Adina Abdelatif and Dr. Rashid Darwish if available. What about the BD and the fatigue? This is my simple question. So can we hear from, before their questions, that we can hear from Dr. Adina or Dr. Rashid Darwish if available?
مساء الخير.
مساء الخير.
أهلا دكتور إيشا.
How are you, Dina? Yes, it's your time, your microphone. The other coin of dialysis is your PD.
Yes. Well, the fatigue and the post-dialysis fatigue that is quite prominent with the hemodialysis might not be the same with the peritoneal dialysis patients.
Sure.
Because the dialysis is like a normal kidney that is functional. Can you hear me well?
Yes, it's a slow technique. So rapid change in osmolarity is unexpected.
And
continuous, more physiological for sure.
And there is no this drastic shift of nutrients in the peritoneal dialysis like in the hemodialysis. So of course this is much less with the peritoneal dialysis. And
but the albumin loss is around 20 grams. So
yes, but this can be.
Yes, there is worry about 4 grams 3 times a week, and PD is more than 20 grams. Yes, corrected by nutrition.
Correct.
Yes, but we can
by nutrition and
4 grams 4 hours.
More physiological, as Professor Dina said.
4 grams in 4 hours. It's considerable loss, and I think a correction is not that occurs in PD.
Yeah, exactly. And you can be corrected. This can be corrected. This can be corrected with the type of fluid that is used, with the type of the dialysate that is used, dialysis fluid. So this is not as a big issue as in the hemodialysis.
In hemodialysis, also, we understand that the osmolarity shift is one of the players, as Professor Faisal said earlier, that it could be related to fatigue syndrome.
Yes.
And your question?
That maybe we should promote for the home dialysis or for the home hemodialysis even for those who can afford it, because this will give us this benefit of the time, and the patient can be dialyzing daily, and many can afford doing this in Egypt or in many countries. So home hemodialysis should be promoted, and I think this is the trend nowadays.
Yes, it's theoretical, right? It's theoretical, right? But we didn't find any in the literature. Probably, Saied, did you read about home dialysis and fatigue? I didn't find something like that before.
Actually, the row for this home hemodialysis was very high, maybe 10 years back. And then again, it comes down in the last 2-3 years. And this is confirmed by Professor Faisal once a day, maybe 2-3 months back on this CMA program. And we can hear from him because he has already some experience with this hemodialysis in Saudi Arabia. If he can, please can tell us what is his experience regarding this issue.
Professor Faisal?
Okay.
Is there the Dr. Yasser?
I am not sure.
Thank you. Thank you very much.
Yeah, is there. Yeah.
Well, I have point to be discussed, and also I will mention about home dialysis. The first point is about we wanted to do something inside the dialysis unit in order to make the patients happy. So entertainment during dialysis, is it decreasing the fatigue post-dialysis or not? I think this point for discussion, because there are many RDU are doing some entertainment for the patient. So they let the patient to love to go to for hemodialysis. Probably this will decrease also the fatigue after dialysis. The second point, which you asked now about the home dialysis. Unfortunately, the home dialysis now it is very for the very elderly patients, very sick patients, and they usually no one can come out, either they are happy because they are staying with their family or not, but this is usually the wish of the family to stay to see their patient with them during dialysis, not to go to the hospital. So I cannot say that they are the fatigue is less, because usually they are very fragile, very elderly. They are not young.
They already have frailty, so we cannot measure fatigue here. They are fatigue all the time. They have sarcopenia and the frailty, malnourished, so a lot of mixed. And as you just perfectly highlight that exercise during dialysis is good for clearance, good for adequacy, good as well for rebound phenomena. We have a lot of publication from Manchester University about that, and they may improve. And we cannot do intradialytic exercise, can do laughing, and laughing now is possibly and exercising during dialysis. And in Europe, there is some center treating that, and in Far East, dancing during dialysis is one of the not only psychological element, but as well musculoskeletal training and physical exercise.
You mean motivating?
Yeah, motivation. So returning back to, thank you very much, Professor Faisal. Returning back to,
thank you,
Professor Sam. I think it plays on the depression that Professor Saied mentioned it many times. Professor Sham, we have many questions, and we
yes, we have to come back to Dr. Adina.
Yes, rapidly, please. One is from Dr. Rami. He asked about the best assessment tool you recommend to avoid a lot of bias, and also if we want to go ask patient about recovery time, how frequent we need to ask. He asked about assessment, Professor Saied.
Yeah.
Is it report frequency, guidelines or something like that?
No. There is no guidelines regarding this issue. Actually, it's just a matter of speculation or suggestion that you, from this study I mentioned, you can just with this simple question, even in your daily clinical round in hemodialysis unit, to ask your patient for how long you take regarding to get rid of this tiredness or exhaustion post-dialysis. If he will mention that it's more than 2 hours, so we shall consider this patient having what's called post-dialysis fatigue. So it is just a simple question you can ask even in your daily practice, in your clinical round in the dialysis unit.
From a question from Dr. Muhammad Abdelbari, what is the safety test used if fail after correcting other factors? For recovery after correcting other factors, what do you recommend the best antidepressant to be used?
I couldn't hear you, Professor Yasser. Can you repeat the question, please?
What is the best antidepressant to be used if we failed to correct all other factors?
It is it is difficult to answer, Professor Abdelbari. But anyway, if we ask this psychiatrist to come to as a consultation, usually they prescribe this Lostral, okay, as an antidepressant. But we should not forget that even this Lostral is not an innocent medication. It can lead to bleeding, as it is anti-serotonin and or serotonin reuptake inhibitor, and in the meantime can lead to platelet dysfunction and consequently bleeding. Even it can lead to also some other side effect. But it is proved that it could be beneficial as an antidepressant in our patient, and in the meantime, it can combat uremic itching and dialysis-induced hypotension. So usually they prescribe this Lostral.
Sometimes Cipralex, Septopram, and all are serotonin. All are serotonin. But I recommend half dosing. For example, if you are taking Septopram like Cipralex, I start with 5 milligram, not with 10 milligram.
Yeah, right, you are.
Question, Dr. Khalid Abu Zaid asked the question that I think we really answered in this discussion. What is the incidence of fatigue in general population CKD PD in comparison to each hemodialysis patient? And the second, what we were talking about, the exact definition of fatigue. And I'm coming to my question, how can we differentiate with the usual fatigue and the post-dialysis and dialysis-related fatigue, which I really think it is difficult job.
Unfortunately, Professor Khalid, we cannot answer this question because, as I mentioned in the presentation, all these studies, despite it is a small size studies and observational also in the meantime, they couldn't answer your question, really. The exact definition, in the meantime, the difference in incidence between CKD non-dialysis patient and in dialysis patient, but for sure, it is higher in the dialysis patient. You see the range, even in dialysis patient, it's between 26 up to 86. So it's a big range because the measurement, it is not, are you not using the same standard or
questionnaires?
Yeah. So
it's just a questionnaire. But in Song, it is on the top. If you find the pyramid of Song standardized of nephrology and on dialysis, you can find in this pyramid on the top, fatigue and the cardiovascular deaths and the mortality are on the top of the pyramid. It's important, but we cannot scale how much is it, how it's powerful or not, is severe or mild or moderate, just we can measure the timing of recovery.
But for sure, it is more in hemodialysis rather than non-hemodialysis patient.
And for sure on CKD.
Yeah.
We have comments, and I will leave Dr. Osman, and I will start by Dr. Safwa Tolan. She is asking about could nocturnal dialysis be a project in high-income countries where many patients can afford? And she is thanking you for this very interesting lecture and session. Nocturnal dialysis.
Again,
Professor and the Professor Shab, it is okay if it is available or affordable. It is okay, but in our low-income country, it is actually it will be very difficult.
Why not to put in between conventional dialysis and the nocturnal dialysis to prolong dialysis? For example, if you are going from 6 to 8 hours,
the same as nocturnal dialysis.
Yes.
Dr. Osman is commenting by 2 comments really. The one and I think they are about my questions. One question I asked and one that I was about to ask. She is commenting about we used the median cutoff albumin decreased at the beginning and then after 12 to 24 weeks nearly returned normal as the patient eater. So Here, the clearance is the lymph that is more powerful than the albumin loss. It results in more improvement of albumin than by the improvement of appetite. And also,
I will point that for Rola. Just saying hello for Rola.
Leave me for one point.
I'm not hearing you.
For PD, we use automated PD fatigue. With the use of automated PD, fatigue is less significant. Please, Professor Hisham.
Yes, thank you, Rola. Hopefully you are doing well in Saudi Arabia. I know that. And one of our ambassador in Saudi Arabia. Yes, you are right. In using medium cutoff, albumin decrease at the first, then return back to normal. Even endotoxin transfer, they are saying that endotoxin transfer due to big pools are comparable to other hemodialysis membrane. But there is no improvement in the expanded dialysis or medium cutoff dialysis over other modality in the cardiovascular risk or other additional factors. So if you are using medium cutoff, be sure that you cannot use it in hemodiafiltration, for example, because they don't mix it that with hemodiafiltration. You can expect the albumin loss, and you have to encourage more protein intake. For your second question, we discussed before on BD, so we can CKD and BD is included in fatigue definition.
And this is my question, last question, really, about what is the role of vitamin D deficiency, which is common usually in dialysis patients, in this symptom, this important symptom, vitamin D deficiency.
We didn't find a direct correlation between CKD, MBD, and fatigue. There is no direct correlation by any. Even Professor Saied say that according to UF rate, they find a U-shaped below 5 and above 15. Yeah. So there is no explanation why below 5 you have a fatigue. There is no any physics or physiological or solid transport or fluid removal can explain why lower ultrafiltration rate has higher fatigue. So we cannot combine any parameter for the fatigue syndrome except usually with tuber necrosis factor inflammation, one parameter, branched chain amino acid nutritional status, protein catabolic ratio is related as well to fatigue, and finally, shorter dialysis and changes in osmolarity is highlighted for such cause, but not in MBD.
Yeah, I think as a common sense rather than an evidence-based, Professor Hisham, as Dr. Rora asked, the existence or the presence of other comorbidities or complications or remote complications in our patient may magnify these
symptoms.
I mean, CKD, MBD, or anemia, or cardiovascular
osteoporosis, and others.
So for sure, it will add something to this point. Yeah.
But it is not directly related.
For sure, yeah. And it is not mentioned even in the literature up to now. Yeah.
We have to improve all parameters.
That is what, as you said, always the optimal dialysis, our target.
16 point.
And the KT over B only 1 point among them.
Yeah, I like that you are the first one to put the T in a capital letter in KT over V.
After your...
Yes, 5 years ago, I put the T in the capital
I remember,
in KT over V.
I remember.
Thank you. We have no more questions and no more comments, and we are to close now. Thank you, Professor Saied, for this very interesting, highly comprehensive talk,
Welcome.
as usual. And thank you, Professor Hisham, for leading this session in a very smart way. And thank you for all professors who attended the session and shared with us for very, very valuable comments and questions and interactions. And for all our attendees who reached this session with their presence and their questions, and you are still running for these one more questions till now. And thank you very much. And excuse me to close this very hot session. And before I close, always, as usual, I will announce about the coming session will be by Professor Mu'taz Fathi, about imaging in kidney transplantation. We will address this way in a case presentation way. I'm presenting some cases regarding imaging in kidney transplantation coming Wednesday, inshallah, in the same time, 9 p.m. Cairo time. تصبحوا على خير. السلام عليكم ورحمة الله وبركاته.
مع
شكرا
السلامة.
دكتور ياسر عليكم السلام. شكرا دكتور هشام.
مع
شاكرين
السلام عليكم.
دكتور طارق.
اشوفكم على خير.